Hello, welcome to Atropia Medic School. Today we're going over Pharmacology 1. This is a two-part video series with several questions, pharmacology related for EMT students. Let's get started. First question, which of the following refers to a medication that activates a particular receptor? A, stimulant, B, agonist, C, antagonist, or D, depressant? Take a moment, pick an answer, pause if you need to. And we're looking at agonist as the correct answer. So agonist refers to something that activates a receptor, so it binds to it, it initiates that process or accelerates a process. I can spell, I swear. Accelerates a process. So a good example of this would be something like epinephrine. We know that it has a lot of beta receptor properties to it, meaning it's going to bind to beta receptors in the heart, the lungs, elsewhere in the body, as well as binding to something called alpha receptors in the blood vessels. And it's going to cause things like higher heart rate, increased squeeze of the heart, or inotropy. We're going to constrict blood vessels, things like that. That's all due to it activating or being an agonist to beta receptors and alpha receptors. In contrast, an antagonist is the opposite. It inhibits or slows, inhibits certain types of receptors, inhibits a receptor, or slows a process down. So for example, we think of something like naloxone. Naloxone is our opiate reversal agent. We can give it intranasally amongst other ways such as IVIM. But at the end of the day, what it's doing is it's binding to opiate receptors in the body. It's shutting them down. It's kicking the opiates off of them, and then we're reversing the opiate overdose. So it is an antagonist. It's an opiate receptor antagonist. Now, depressant and stimulant are a little subjective, but the way I interpret these things, because they're a little subjective, is I tend to think of, for example, like CNS depressants. Alcohol is one. Benzodiazepines are another. When I think of depressants, things that are going to reduce CNS activity. In contrast with a stimulant, we think of things that increase CNS activity. So for example, cocaine is a stimulant. It has a lot of sympathomimetic properties. So medications that activate the sympathetic nervous system, things that have sympathomimetic properties to them, we tend to think of as being very stimulatory, like epinephrine. Cocaine, methamphetamines, ADHD medications like Adderall, those are all have stimulatory properties, or are CNS stimulants, if you will. Again, a little bit subjective, but more importantly, know what an agonist and what antagonist means. If you know that, you should be okay for the test. Next question, a patient with chest pain wants assistance with their nitroglycerin. You note the prescription is expired. This is a violation of which of the following medication rights? A, right patient, B, right medication, C, right route, D, right time, or E, right documentation. Take a moment, think of an answer. And here we're thinking about D, right time. Right time is referring to an expiration date usually. And I will caveat this with, you look at a lot of resources and they'll tell you there's 5 medication rights, there's 8 medication rights, there's 13,000 medication rights. There's some basic ones you should be aware of, and you should be able to identify, like, okay, this is not really a parameter we care about. So right patient, if we're going to assist a patient with their own medication, it has to be their own medication. You'll see questions sometimes pop up where a patient has nitroglycerin, but it's their spouse's. Obviously, that's not the right patient. We can't assist them with that. Right medication, for the love of God and all that is holy, always read the bottle of whatever medication you are looking to assist or administer to a patient. A lot of bottles will look the same with some very similar looking words or names of medications on them. This is a potential area for medication error that we do not want to mess with. So always make sure that you read the bottle, because that bottle sometimes looks like one thing, but it's actually another. Right route. Not every medication can be given certain ways. For example, oral medications can't just simply be given through an IV. Likewise, a lot of my IV medications, if you're an ALS provider, can't actually be done the oral route because they're not formulated to get absorbed through the GI tract. So knowing the proper route of administration is really important. Another example of this at the EMT level would be like epinephrine. We can only utilize intramuscular epinephrine, whether it's an EpiPen or we vial draw out 1 to 1,000 epinephrine. We can only give it intramuscularly. We can't do it other ways. So that's an important thing to note. And then right documentation. That's always important. It's always important to document whatever you do. If something beneficial happened as a result of what you did, great. If something negative or untoward happens to the patient, document that as well. If you followed your protocols and something bad happened, that's not on you, because you did not do anything to violate your protocols. You did your due diligence. It's when you do things like give nitroglycerin to someone who you didn't get a blood pressure on and you bottom their blood pressure out, stuff like that, that becomes problematic because you didn't do what you were supposed to do. So this is why it's always important to document everything that you do appropriately. All right. Which of the following receptors would increase cardiac contractility when activated? A, beta-1 adrenergic receptors. B, beta-2 adrenergic receptors. C, alpha-1 adrenergic receptors. Or D, muscarinic receptors. Take a moment, pause if you need to, think of an answer. And here we're looking at A, beta-1 adrenergic receptors. A good way to remember this is we have one heart. So beta-1, one heart. And what do we see with beta-1 agonists? We're going to see an increase in the heart rate, and we're going to see an increase in the squeeze. We refer to that as inotropy. So there's more contractile force. When we look at beta-2 receptors, we think mostly the lungs, particularly the bronchi. And we see when we have beta-2 adrenergic receptor agonists, so we're activating those receptors, we think of bronchodilation. So for example, albuterol is a beta-2 receptor agonist. It's going to cause bronchodilation by binding to those receptors in the bronchi. Let's choose a different color. Purple looks good. Alpha-1 receptors, these are interesting. These are in the blood vessels. You do have beta receptors in the blood vessels too, but for our discussion today, we're really not going to focus on elsewhere where beta receptors are. We're going to focus mainly on the heart and the lungs. But alpha-1 receptors, those are also adrenergic receptors, meaning they respond to things like epinephrine, dopamine, norepinephrine, these catecholamine substances that have a lot of sympathomimetic properties to them. So what we have here is when we activate these receptors, we're going to increase vasoconstriction. So we think of a patient who's in shock, so they're not getting enough perfusion to all their organs. One thing we can do to increase that perfusion is jack up the blood pressure. How do we do that? Vasoconstriction. So epinephrine, norepinephrine, dopamine, other substances in the body bind to these alpha-1 adrenergic receptors, and they activate them. They're agonists, and they cause vasoconstriction. Now, at the EMT level, you do not have to have a fundamental understanding of how acetylcholine works in the body. This is not super important, but I'm going to take a brief detour here, and we're going to just mention it. So, muscarinic receptors, those are associated with the parasympathetic nervous system. So we know that the sympathetic nervous system is fight or flight. nervous system. So this is our kind of part of our rest and digest part of our nervous system, although it's obviously more complicated than that. I'm mentioning this because with muscarinic receptors, those are predominantly in mucosal membranes. And so let's say I get exposed to something that my body really, really doesn't like. It doesn't want to absorb it or anything. Guess what? I'm going to pump out more mucosal secretions. That can be in the GI tract, which is obviously very important for digestion. But it can also happen in like our respiratory tract, our nasal passages, things like that. Mucosal membranes are being kind of hyperactivated because they have a lot of muscarinic receptors that are being activated by something called acetylcholine. Why? Because we're getting exposed to something our body doesn't like. And how do we kind of protect ourselves from that? Just increase the amount of secretions to keep it from getting in the body. So this is also why when you get sick and you get that super runny nose and you get really, really congested, those mucosal membranes are getting super inflamed and pissed off and secreting a bunch of stuff to protect your body from like getting more stuff into it doesn't want. This is as basic as we're going to keep it. We're not going to really go into much more detail. At some point, we will talk more about the parasympathetic nervous system, but that's story for another time. Next question. A patient calls for severe dizziness. You note a blood pressure of 86/50. The patient admitted to taking nitroglycerin due to chest pain, but also took sildenafil at night. Sildenafil is an erectile dysfunction medication known as Viagra. This is an example of A, synergistic effect, B, untoward effect, C, contraindication, or D, all of the above. So take a moment to think of an answer. And it's going to be D, all of the above. Let's break this down a little bit. So a synergistic effect, I always like to describe it as 2 + 2 = 6. So two medications that have kind of not necessarily the same mechanism of action, meaning how they work, but the end result kind of causes the same thing. In this case, both of these medications cause vasodilation. They cause lowered blood pressure. And when you take both of them together, you get a further magnified effect of whatever that is. So in the case of nitroglycerin, NTG, and we take something or some sort of ED medication in relatively short period of time, you get a magnified decrease in blood pressure, significant decrease in BP. And that's why in a lot of your protocols, as well as what you were taught in class, we always ask patients before we give them nitroglycerin, hey, do you take any medications such as Viagra or whatnot? Because they have a synergistic effect with each other. Obviously, hypotension or low blood pressure after the administration of any medication, that is an untoward effect. So all untoward is referring to as it's undesired. We did not intend for it to happen. It's not, I don't want to necessarily say it's good or bad. Sometimes these things happen. As long as you did your due diligence and made sure they had you got a blood pressure, you asked about ED meds, you'd be surprised some people will not be upfront about it and they may lie about it. And that's not your fault if they do that. So don't think that makes you a bad provider. These things sometimes happen. Contraindication. We know that in most of our education content, as well as in a lot of state protocols, they explicitly state somewhere between 24 and 72 hours time span is needed in order to actually be able to give nitroglycerin after having used something like sildenafil or Viagra. So given A, B, and C are all correct, we are left with D, all of the above. Moving on to the next question. You have a patient who has an opiate overdose. You note vital signs of heart rate 110, blood pressure 90/50, respiratory rate of 6, and irregular. You should A, administer high flow oxygen via non-rebreather mask, provide ventilations, administer naloxone 2 milligrams intranasal, or D, call for ALS. So take a moment, pause if you want, Think of an answer. And our correct answer here is going to be B. So this is a little bit of a trick question. We know that this patient's an opiate overdose. Yes. We know that the preferred way of reversing that is going to be with naloxone. So that is our reversal agent. But the problem is that we have not addressed the underlying like ABC life threats. We always need to first address ABC life threats before we actually move on to our medication. Another way of thinking about this is if I don't have adequate ventilatory support, it's going to be kind of hard. The medication is just going to kind of sit there in the nose, which is, fine. But if I'm not circulating oxygen around the body, the medication is not going to be very effective. So we want to make sure that we have our ABCs in place and we're addressing those. And then once those are in place, we can now administer the medication. We talked about in our airway and respiratory videos that it's not sufficient to use a non-rebreather mask in respiratory failure. So don't use in respiratory failure. If you're identifying someone that is unable to properly ventilate or oxygenate, which it's pretty clear this patient probably is, we need to actually utilize BVM ventilations. And as I've mentioned in previous videos, we know that we should call ALS if we're at the EMT level and we need help. That said, the test takers know you're going to call ALS. They know that you know to do that. That's a pretty obvious thing because they beat that into your skulls in EMT school. They're testing on, do you know what you need to do next to stabilize the patient while you're waiting for additional resources? So for that reason, generally D is not an answer that I would pick unless if all the other answers sounded like awful. Another thing to think about here is we have vital signs. We know this patient is unstable. We have to address instability regardless of, whoever is coming to help us. So, last question. A patient has wheezing, urticaria, and angioedema. You administer oxygen without improvement. Their vital signs show that they are in shock. You should A, administer a beta-2 receptor agonist. B, administer a non-selective beta receptor agonist. C, repeat vital signs every 5 minutes. Or D, administer a beta receptor antagonist. Take a moment, pause if you need to, think of an answer. And here we're going to pick B. This is kind of hinting at epinephrine being our drug of choice when we're talking about someone with anaphylaxis. So yes, they have wheezing. Got it. Cool. That said, they have urticaria, angioedema. Angioedema describes basically, I like to think of it as airway swelling. But these patients' faces are usually super swollen up, big fat tongues, their eyes are super puffy. There's a lot of potential for airway obstruction here. So this is all just screaming anaphylaxis. Anaphylaxis. I can spell, I swear. There we go. So with that in mind, sure, I could give them albuterol, but that's only addressing one small component of this. And that's what we're going for in A. They're talking about albuterol, a beta-2 receptor agonist. And that's going to be insufficient to address the rest of their symptoms. Now, should we repeat vital signs every 5 minutes? Yes. But the test is giving us some prompts telling us, hey, we need to do something immediately. Vital signs, they're great to do, but if I had to choose between doing an intervention and doing vital signs, I will choose doing the intervention over the vital signs. So not the best answer here. An antagonist, we talked about this word, and it means inhibits. We actually don't want to inhibit beta receptors here. Why? Because if I inhibit the beta receptors, I'm allowing more of the parasympathetic nervous system to take over. That increases secretions, which is already an issue in anaphylaxis. It decreases the heart rate, which can potentially be bad in anaphylaxis. It decreases blood pressure, which can potentially be bad in anaphylaxis because those patients are predisposed to hypotension. So medications like metoprolol are what we think of as a beta receptor antagonist. They end in LOL. So that's not really appropriate for us to give. So this concludes the first part of a two-part series on Pharmacology 1. Like and subscribe to the content if you really enjoy it. If you have suggestions for how to improve it, absolutely leave a comment below, and we'll see you next time.